check check. بسم الله الرحمن الرحيم. check check. check check check.
Test check mic. Test check. Check mic. Test check mic. Test check. Test check mic.
مايك تيست check. علي الجيم بتاع ده يا احمد.
كريم انت ممكن تعمل رينيم للاسم دوت تعمله باسم اسبين.
اني
اسم كريم ايوه.
هحاول. تيست check مايك تيست. مايك تيست check. تيست check. شوف هناك رافع معاك ولا لا. تيست check مايك تيست check مايك.
Hello, Dr. Kem. How are you? Hello. Hi, doctor. How are you?
Okay, there's Arabic.
Hello.
only hear static. Very loud static.
I think we should try to close this. It might be too much work.
Doctor, your voice is fluctuating as well, so we just need few moments trying to fix it.
Okay, thank you.
Now we can hear you very well. Can you hear me as well?
Yes, much better.
Okay, this is perfect. And by the way, we're so sorry to be late, but it took us a bit longer than expected to arrange the equipment, so we're so sorry for that.
No worries.
I guess, doctor, for the sound, it's all good. Would you please try to present your slides?
Hello there. Now I see you.
Perfect. This is Suhaib, and this is Dr. Asri.
Hi. What do I do to find my slides? Do I jump out of this view, or do I just find my slides?
Just let me check for you. Doctor, you can just go directly. You can just go directly to your PowerPoint presentation and open it. It will be appearing on our screen. You're a presenter now.
Okay.
So on our screen, we can see your face and we can see your laptop screen as well.
Okay.
Plus
Can we see her face in front?
the slides and the face together.
Up the slides.
Yes. Yes,
Do you
perfect.
see us? Do you see us?
I don't see you guys at all. I see my slides,
Okay.
and I see me.
Do you see the room? No, you don't see the room.
No, not at all.
We will.
There's oh, okay. Yes, now I see you. Oh,
You have also your slide.
where should I put that view screen though? Because I can see people moving around in the room, but the view screen then overlaps my slides that I'm trying to present.
Okay. So how are you? the our screen. You just need to scroll the so your slides will be appearing in the middle. Can you see any screen to scroll? Any line? Sorry.
No. What I see is it says go to meeting viewer, and I see me and I see you, but it's a fairly big box that covers over top of my slides.
Okay. هلا بس هي برضه بدها يعني هي she wants to present وتشوف القاعة. Is this she can do that? اوكي لا هي طالعين يعني بس very big font. هي فكرة to scroll
There is like a drop down box that says everyone, and it says you who's talking, view presenter, wide webcam.
Thank you, presenter.
she's a presenter.
Are you clicking on the you presenter?
No, there's two boxes. One which I was able to reduce, and that one has talking, me. It shows me, and then it has audio screen and webcam, and then it shows audience view, attendees, and chat. And that's how I first spoke to you. So that one I reduced down, and it's just a tiny little bar that I can get out of the way. The other screen says go to meeting viewer, talking, me, Kimberly Steele, and then there's two drop down boxes, everyone. And when I drop that down, it says view everyone, view who's talking, view presenter. And then there's webcams that says always in front, hide my webcam, hide all webcams. And there's a preference box. I'm just not sure that this box really does get in the way of the slides as I'm talking. Michael and Matthew, maybe you can help me set up a nicer view in the back. All I see are the curtains.
Just give us a moment, please, doctor.
Okay, no problem. I don't know if I move it over. No, you know what it is? This chair is so big. Maybe.
بس مش الفول سكرين.
المفروض لما هي تختار من الابلكيشن فول سكرين تظهر عندها فول سكرين زي ما انا كنت عامل كده. انا لما فتحت دي
احنا بنشيل اللي عندنا، احنا هنشيل احنا من عندنا وهي هتشوفها عندها، هتبقى شايفه الاثنين برزنتيشن وهتبقى شايفه
هتبقى شايفه البرزنتيشن وهتبقى شايفه صورتنا برضه.
ايوه عايزين كده.
ما هو طول ما هي بتدي البرزنتيشن مش شايفينها، بس دي عندها فول سكرين برضه.
فلازم تصورها.
مش لازم تبقى يعني حتى لو صورتها ممكن تعمل حاجه تانية.
This is just testing. Just testing.
قادرة تشوف السكرين، قادرة تشوف دي عندها.
اوكي.
نفتح باوربوينت.
Michael hasn't seen you. No, he did. Yeah. If you get too close, then you'll be in the camera.
بس هي راح تشوف هيك برضه بس
يعني هي مش هتشوف اللي احنا عاملينه ده.
Well, funny because
الباوربوينت بتاعنا
it's
لا بتاعها هي، هي اللي راح تفتح. Excuse me, doctor.
Yes.
Can you please exit your full screen presentation
Okay.
and then go to slideshow?
Okay.
Slideshow.
Set up slideshow.
And then set up slideshow.
Uh-oh. Hold on now. I just lost my presentation.
It's fine.
Uh-oh. Okay. Is that under home or?
No, it's a slideshow. 1, 2, 3,
I'll go
4,
to
5,
slideshow.
6.
Yeah.
Yes.
Slideshow. Okay. Set up slideshow.
Yes. And then
All right, I'm there.
browsed by individual window.
Okay.
Okay.
And then hit OK.
And then okay. And then the full
Alright.
screen. Full screen icon.
Okay.
Okay. So, doctor, you can see your presentation now?
Well, now I have a box that says you've been made the presenter. Please close confidential windows.
Okay, ايش لازم تعمل هلا؟ Yes, then you accept to be a presenter.
Okay.
So now we can see your presentation, your face, and the room. What can you see exactly?
I can't see my presentation. I see your room and I see me. Oh, no, that was weird. And it says, oh, now I can see my presentation because I clicked out of the viewing box.
Yes, exactly.
And it says,
and then you can open.
it says people can see me.
هلا هاي الشاشة اللي طالعة عندها. Okay, then doctor, can you please minimize the GoToMeeting screen?
Yes.
Okay, and then open your PowerPoint presentation.
Okay, I've got the PowerPoint presentation here.
But just minimize the GoToMeeting screen first.
I did. Let's see. Yeah, all I have now is my PowerPoint presentation.
So you can see yourself and the room.
No, I can't see anything except my presentation.
Excuse me, doctor. He's gonna be requesting to control your screen. Would you please allow
Sure.
him? Okay. Would you please give him the permission?
Yes,
you have
I
control.
did.
Okay.
It says you've got my control. Did you want me to start from scratch again in my email or?
I'm not really sure. ايش عم تعمل هلا انت؟ هي داخلة على الويب سايت، أنا بعت لها تدخل على الويب سايت.
انا عايز الابلكيشن.
طيب نزلتها
Here,
بالابلكيشن.
use this one.
احنا ما حكينا ننزل ابلكيشن، احنا بعتنا
هو
لها لينك ويب سايت.
المفروض ان كله بيشتغلوا على بعض.
هلا انت عم بتنزلها. Doctor, we're just downloading the application to your computer.
Okay. All right. Here. Stop. Try now.
No, you just need to go to the link.
You need the ID number. I just put the ID number in if,
This is join, and he will enter this group. He will be directly escorted to our meeting.
الاي دي نمبر مش هو اللي معانا. طيب
is it working or not?
I don't know. Not showing anything. It's showing the thing, but it's not showing anything green.
Oops. Still 5 p.m. وبلشوا.
I hope they will not disturb us.
They will, I guess. يطول. Excuse me, Dr. Kim. We're gonna do something now, please. We need to
Okay.
close. We need to close the session through the browser, through the Internet Explorer, and would you kindly ask you to open the meeting through the icon that was downloaded at your desktop. It's an icon, so you don't need to go to the website.
I understand. Okay.
Please? Thank you, doctor. Doctor, you closed the Internet Explorer and you connected through the icon, the application.
Yes, so I see the icon and I clicked on it, but all I have now is a view of the room.
Okay. هلا هي شايفتنا احنا. ما طلب منها كود ولا شيء، لقيته وفاء.
انا عايزه تخرج من السيشن
ما هي طلعت من السيشن على البراوزر تطلع من الابلكيشن كمان مره.
هي دلوقتي فاتحه من الابلكيشن. خلاص تعمل شويه.
Doctor, can you see a screen icon? It's in the GoToMeeting page.
Where I see the room, and then I have another screen called Go to Meeting. It shows that I'm the one talking.
Mm-hmm.
And then there's audience view, attendees, 3 of 151.
Okay.
Oh, now I have a picture of me and the room, but not the presentation.
Okay. So ايش هلا تفتح البرزنتيشن؟ هي شاشتها. طيب هلا ايش بدك تعمل انت؟ Would you please accept the control, please, doctor? Okay, the presentation is now showing.
Uh-huh.
كيف اسوي؟
سكرول من هنا and drag and drop بقى.
Would you please accept the request for control?
Oh,
Do you see the room now? Ah, the screen is freezed. Something is freezed.
Hello?
Hello, do you hear us?
Yes, I hear you.
Yeah.
I shared my keyboard with you.
We will do simple. I think during your presentation you will see your slide, not the room. We will see
Okay.
you and see the slide. And then after your presentation, when we will enter the session discussion, you will see the room.
Okay.
And then you will be able to answer us. I think it's a little bit complicated to have your slide and the room in the same screen for you.
Okay, that's too bad. It's a little.
I'm sorry for that, but
I just won't be able to see what the audience is thinking.
Yeah, this is what I think as well, doctor. So we're gonna give it another try.
yes,
So
we will.
if you don't mind.
Yeah, we will try. We will try and
Okay.
see if it works. Otherwise, we will. Do you remember when we did it with Skype last in May or last year? Did you see the room in the same time?
I don't remember. I think, yes, I remember that you were sitting around a table,
Yeah.
the group.
Maybe with Skype it's easier. We will check. If not, we will do it by Skype. We'll try to do a test by Skype if possible.
Okay.
The website, not the website, but what? Okay, we will try another option. Could you please close your session, shut down everything, your computer, restart your computer, and then click not on the link of the website, but on the icon on your screen, on the desktop.
Okay. Okay.
Then we will
All
go
right.
to the application and not to the website.
Okay. So this icon down here.
And
That's
then you will re-enter the passcode we sent you.
And re-enter the passcode.
Yeah.
Okay.
Thank
so
you.
this is the icon you want me to push.
Yeah, thank you. Sorry for that.
No. Okay. I'll click out of everything. Here I go.
Okay, see you in 3
Few
minutes.
seconds.
Thank you.
looking at me that I can't see. Hello? I shared my keyboard again.
Okay, doctor. He's checking.
Okay, so just so you know, I shut my computer down, I restarted, but the icon disappeared. There's no icon. So I had to join you through the link again.
Okay.
Might be that the internet's not strong enough here. So the other thing is, right now, I'm on a laptop using a Pulse Connect to Hopkins.
Do you think, doctor, that this makes the connection slow?
I don't know. So right now, just to let you know, I'm away. I'm visiting University of North Carolina Department of Surgery as a visiting professor today and tomorrow. And so I'm sitting in a hotel room and I don't know. I've got the Hopkins server on right now. I don't know if that will slow it down or improve it. But I've got, hotel internet connection.
Okay, so let's give it a try now.
Maybe they could stop for a second and try. Michael Matthew? Could you come off the internet for a minute? Because I want to make sure that we're not interfering with Mom's work right now.
It doesn't because it's the internet for
Doctor, we're just trying to download the application to your desktop.
Okay. I saw your room for a second. There's your room.
Doctor, can you see now the icon appearing at your toolbar down in your
Here?
desktop?
Yeah,
Okay.
I see it. There's two of them right now.
لا لسه
No.
ما دخلت. ايش تعمل هلا؟ تطلع من الويب سايت وتدخل على الابلكيشن. So would you please close the website and then try to join through the application again?
Okay, now, just to let you know, the last time when I tried to close the website, the icons disappeared.
Okay, I guess this time we downloaded it properly, so it should be appearing on your screen.
Okay, so close everything up and click on the icon, correct?
Yes, please. Yes, please.
Okay, here I go.
Thank you, doctor. شبكات.
Hello there.
Doctor, you're now connected through the application, right? The icon, I mean.
No, the icon disappeared again.
Oh,
Now
oops.
it's back. As soon as I click out of the application, the icon down here in the toolbar disappears. So I used the code and joined again. Currently, I see your room.
شايفة أول room. Can you see your presentation, doctor? حطها presenter طيب.
You want me to share my keyboard again?
Can you please open your presentation? Okay.
Yeah.
طيب هي كده بص هي كده لو فتحت
Now, should I do the same thing as far as the slideshow?
Yes, please, doctor. Yes.
Set up slideshow,
And
browse
then-
by an individual?
Yes, exactly.
Okay, and okay.
Yes.
All right, that's done.
Okay. بعدين طب تعمل فول سكرين راح هلا هي شايفه Okay, doctor, can we try one thing? I would like you to
Yes.
kindly please resize the screen of the presentation, the PowerPoint, manually,
Uh-huh.
just to fit your desktop screen. لا maximize راح تغطي على هاي.
Like so?
So you just need to resize it. You just go by your mouse
Uh-huh.
to the end of the PowerPoint screen and drag it to the right and left.
Where am I putting it?
Uh,
Like so? Then I see there I see, so right now I have the PowerPoint screen and I do see your room.
Okay. إذا أنت أخذت الكنترول تقدر تظبط لها البرزنتيشن. بس. Okay, doctor, we're gonna take the control now.
Okay. I did give you control. Yep. No, this is not working now. Oh, it does. Okay.
Doctor, you received webcam request as well. Can you please accept?
Yeah.
Okay, بس هلا احنا صرنا احنا شايفينها بس هي مش شايفة.
Oh, boy.
Okay, ما هي أعطت. We just need the control, doctor, please. If you receive a request,
Okay.
kindly to accept it.
I thought that I did. It does say that I'm sharing it with you. Oh, hold on. Okay. All right, there you go.
Yeah. presenter now? Okay, doctor, so now we can see your presentation and we can see your face and I'm suppose that you can see the room, right?
Yes.
Okay, this is perfect. Would you please try to present the first 2 or 3 slides just very quickly to see if the scrolling is appropriate?
Okay. Looks good.
Yes, finally, that's perfect. Finally. So thank you so much, doctor, for your time.
Okay.
And I guess we're gonna meet you in 1 hour 45 minutes, right?
Yes. Okay.
Perfect. We
Yeah,
can.
it all. Okay. So now, let me ask you: do I close out of this or just stay put?
تفصل ولا تخليه؟ If you can stay connected, it will be okay. Would you like to join the meeting from the beginning? It will be our pleasure, of course.
I would like to do that. I have to run and get my kids some breakfast. What time does your meeting start at?
45 minutes from now.
Okay, I think that I can get back, and I would like to, if that's possible, join.
Okay, this is perfect. I just want to ask you if you can, just to keep your screen open so we don't lose the setup that we arranged finally.
Okay. Now, I am having trouble with this one slide. It's sticking. I don't know why.
Your PowerPoint is hanging out?
Yeah, it's hanging out. This one it didn't want to,
It's now moving, I
have-
guess. Yes, it's working now.
okay, all right. It's just that one slide is sticking. It won't, okay,
Yeah, it's working.
okay. Actually, there is, I had, points on this slide and they're not showing up. I don't know why. It's fine. I'll just talk them out.
Exactly. I think that you can say them verbally. It will be great.
Okay. All right. So we'll see you in 45 minutes.
Yes, thank you so much, doctor. From our side, we will just close our LED screen so you will not be exposed, and
Okay.
we will open it back again in 45 minutes.
That's a good thing.
Thank you, doctor. Thank you. Bye bye. Thank you.
Okay. Bye.
Let's go. My cup has to just run to the gas 45 minutes.
Michael. My mom only has 45 minutes.
Come on
I
now.
have 1 minute.
Okay, she's going to the bathroom.
test check mic test check. ها test, check mic test.
Check, test mic check. Check, text.
هو ليه ده عمل كده؟
Check mic test. Check.
test, check, mic, test, check. Test, check, mic, test. Test, check, mic, test. Test, check, mic. Test, check, mic, 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 test. Test, check, mic, test, check, mic, test, check, mic, test, check, mic, test, mic, test. Test, check, mic, test, check, mic, test, check, mic, test, check, mic, test, check. Test, check, mic, test, check, mic. Mic, test. Mic, test, check. Hello, test, check, mic, test. Hello, test, check, mic. Mic, test, check. Hello. Test, check, mic, test. Mic, test, check.
test.
test, check mic.
present Aspen first? It's up to you. Okay, unless you are present Aspen first, because you are present risk factors, quickly, and then we'll get there.
So this one is for
Yeah, so the laser practice. Is everybody here? We can start. I would like to thank everybody for making the effort in the unusual weather of Cairo today to join us in this scientific activity of the Bariatric Surgery Advisory Board. Our partners in the care of our patients, the industry presented by Aspen Company today, who are hosting our meeting. The aim of the meeting is to highlight the role of anticoagulants in the management of bariatric surgeries, and our agenda will include first a presentation from Aspen for the attendee to know the scope of the company and what she can offer to patients all over the world. And then I will make a short presentation about the bariatric surgery practice as regards anticoagulant and the risk factors which govern our policy in our practice in Egypt in a current practice overview. We were supposed to have Dr. Elie Choulard from France to present the optimum anticoagulation and the study from France. Unfortunately, he fell ill yesterday and he had to be admitted to hospital. We all wish him quick recovery, and we will schedule his visit to Egypt later. So instead we will then follow on by Dr. Kimberly Steele from the renowned and famous Johns Hopkins Hospital. He's a professor there and going to present the anticoagulant policy of their center, and she will be kind enough to receive questions from us and from the floor, and this will be a live transmission from Baltimore in USA. Following the discussion with her, we'll have a short coffee break, and then Dr. Asri will take the role of explaining the results of the study, of the French study that Dr. Choulard we are going to present, and we will finish off with our closing remarks and our recommendations from the scientific activity of today, and at the end we'll have dinner. So I'm proud to present our host from Aspen, Dr. Asri Benkiritli, who is going to present to us the Aspen Company.
Thank you, Dr. Habas. It's a pleasure for me to be here. Thank you very much for having accepted to be member of our first advisory board meeting dedicated to the bariatric surgery and specifically to the anticoagulation in prophylaxis for those patients. I will very briefly introduce the company and talk about Aspen
and specifically in the Middle East, North African area, as the medical director that I am. Aspen. Aspen is a company from South Africa, global supplier and manufacturer of standard and generic pharmaceutical products. We have 25 manufacturing facilities split in 17 different sites all over the world. We have 150 countries where the patients have access to our products. We, every year, manufacture 24 billion tablets, and we have 10,000 employees in 52 countries. We are the largest South African company, pharmaceutical company. Here you can see the 150 countries where we sell our drugs, and you see that those countries are in Europe, in Africa, in North and South America, and in some part of Asia. But talking about our manufacturing facilities, it's important to note that since early the 1997 year until today, we have increased the number of manufacturing capacities, and specifically this Port Elizabeth in South Africa, in Germany, in France, in South Africa also, and in Netherlands are the main places where our drugs are manufactured. This is our Middle East, North Africa, and Turkey region, and you see that we have different type of presence, directly with sales reps, direct promotion belonging to Aspen, and working in some countries with partners or having distributors only in some country very sensitive like Libya or Iran. And you see that in Egypt, we are here, and it's an important country for Aspen. Our product portfolio is splitted in different therapeutic areas, and generics accounts for less than 10% of our sales. We have anesthetic products, we have thrombosis products, we have cytotoxics and hypotension drugs, and we have other different brands like Eltroxin. We will see the details now. In anesthesia, you know, for example, Diprivan. You know drugs like Ultiva, Xylocaine, Nimbex or Marcaine. In thrombosis, you will hear today a lot about Arixtra, which is our main product in thrombosis, but we have also Fraxiparin, which is a low molecular weight heparin that you probably know also. And the key brands like Alkeran, Eltroxin, Imeran are also in our portfolio. And we have other drugs like Solpadine, for example, that are regional brands. I must tell you that KSA, Egypt, and Algeria are the main important countries for Aspen in our region, and they contribute to 60% of our sales. And this is why we are here today, because you're so important for us that we would like to discuss our ambition and our projects together. This is how Aspen is growing and has grown very quickly since 2012-13 in this area. This was my presentation for Aspen. If you have any questions, I'll be pleased to answer to you during the coffee break. And no later, I give you the floor to your presentation, Dr. Abbas, and thank you for having listened to me.
Thank you. Okay. Our bariatric practice is a serious type of surgery in very sick and ill patients, sometimes already coming on with a long list of medical problems, with obesity and the high BMI makes them more liable to complication during the procedure. And to improve the safety profile and the outcome of the surgery, it is important to be careful with every point in the way of the journey of management of our patients. And one of the very serious and probably largely avoidable complications that an obese patient can have during any kind of surgery is venous thromboembolic risks. And these patients are really not all the same. You can have a patient who is a young lady who's 19 years old with a BMI of 39 or 40 with no medical problems, no history of regular medications, coming for a straightforward bariatric procedure which will take less than an hour, hospital stay of about 24 hours. And you can have a gentleman who's 55 years old with BMI of above 65, that 3 or 4 coronary stents in place, past history of DVT and pulmonary showers, repeated admission to ICU, already diabetic, hypertensive, with some respiratory problems, coming for bariatric surgery. So definitely the profile of these patients are totally different. And also the management plan, including the venous thromboembolic VTE risk assessment, should be different, and how we are going to care for these patients should also be different. And one of the ways of the of trying to standardize the practice and making sure that you're getting the best outcome as regards the success of avoiding the VTE problems is to stratify the risk of your patients into levels and plan your management or prophylactic scheme according to the level of the risk that individual patient is exposed to, according to so many parameters. And one of the very nice ways of doing it is the Caprini score, which was published in 2003 and 2005. And in the MENA group, not the MENA T group of bariatric surgeons, we discussed this a few years back, and we agreed that this would be nice to add it to the regular management policy of our patients. So on admission, a patient will go through the list quickly for you. We have to fill on all these data by the first doctor who's going to see the patient to add points. So for each of the following long list, if the patient has had any of this, he will have 1 point from the score. If the age is between 40 and 60, the surgery is being minor, the history of prior major surgery, if he had varicose veins, if he has inflammatory bowel disease, swollen legs, BMI above 30, acute myocardial infarction less than a month, congestive heart failure less than a month, sepsis less than a month, serious lung disease or pneumonia less than a month, abnormality in the respiratory function test, medical patient currently at bed rest, leg plasters or casts for whatever reason orthopedically, and he will have 3 points for other problems which are more serious to induce a higher risk of venous thrombosis, like age above 75, major surgery lasting 2 to 3 hours, and a BMI above 50, which induces venous stasis syndrome. So this is very common practice for us to have patients with a BMI above 50, and you have to notice that this on its own, without the rest of the long list, makes this patient will have 3 points. And you will know later on what these 3 points mean. And you can see also history of DVT-PE, family history of DVT-PE. Cancer, usually we don't operate in cancer patients. Factor 5, Leiden, positive prothrombin 20-21-0A, elevated serum homocysteine, positive lupus, anticoagulants, positive anticardiolipin antibodies, heparin-induced thrombocytopenia or other hemophilias. A patient with this list will have 2 points, age between 60 and 74, major surgery more than 60 minutes, arthroscopic surgery, laparoscopic surgery, and all our cases, almost all now are done laparoscopically. So at least a patient will have 2 points from here and 3 points from being a BMI above 50. So we already collected 5 points for so many of our patients. Again, morbid obesity here, or BMI above 40 will give 2 points also. So if the patient is very high, has the highest risk of problems, will have 5 points for these. But usually these are not in our domain: hip surgery, strokes, multiple trauma, spinal cord injury, lower extremity arthroplasties. And major surgery lasting over 3 hours, this is only for our redo cases where we stay in the laparoscopic procedure more than 3 hours usually for revisional cases, and this will gain 5 points. And these specific points for women on oral contraceptives or pregnant or have postpartum less than a month or had repeated abortions before, they get 1 point for this. So after all this stratification, what does this mean? If the patient total risk, after filling all this with a primary doctor reviewing the patient on admission, if he's collected only less than 1 point, then the risk of DVT is less than 10%, and this what fits the patient I told you about early on, with a low BMI, young, fit, no medical problems, no history of problems. Then this patient has a lower risk of thromboembolic complications, and the regimen will only need early ambulation with no specific measure, just the usual elastic stocking as a legendary, which goes on for every patient who is going to go for laparoscopic procedure, or intermittent pneumatic compression. If the patient score is 2, this means that the risk goes up from 10 to 20%. It's called moderate risk. Then we add to the prophylaxis system now, give to 5,000 units of heparin PID, or the more popular one is the low molecular weight heparin, adding to that also the elastic stocking or intermittent pneumatic compression. If the patient collected 3 to 4, then we go up to 20 to 40% risk, and this most of our patients will fall in this place, the high risk patients. This will have the same like the moderate risk group, but we will add to that the patient will go home on the pharmaceutical anticoagulation for 2 weeks at home following discharge. And it's very important also for this group to make sure that when they are allowed home, they should have been able to tolerate at least 1 liter of oral fluids without vomiting before discharge, because dehydration plays a very important role in the pathogenesis of VTE after bariatric surgery specifically. So the patient is already coming with the high risk factors, and you add to this is being more bedridden after the surgery and not being able to rehydrate because of the nausea or vomiting secondary to your surgery. So you don't rush such a patient out. You have to have the discharge policy to make sure that this patient is tolerating at least 1 liter, achieving 1 liter of oral fluids prior to discharge. Otherwise, he will go to hydration and will increase the risk of his VTE. If the score is 5 or more, then the chances of PE and VTVT will be 40 to 80%, with chance of mortality of 1 to 5%. These are called the highest risk, and you will give a bigger dose of pharmaceutical anticoagulation and a longer duration of at-home anticoagulation for at least 1 month after the surgery. And the high risk and the inclusion of the mortality risk should be clearly defined to the patient in the consent form and to him and to his family. But the safety of consideration, we have to consider if the patient is going to tolerate this high dose of anticoagulation, because we know when we put staplers on the stomach, staple line bleeds, and we have to make an effort intraoperative to control the bleeding. So if the patient is associated with another problems, like the list we have here, then it may not be easy to give him the full anticoagulation dose we are aiming for, and we have to think about alternative like preoperative umbrella to the vena cava or other measures, because if this patient is receiving the full anticoagulant policy we are aiming for, he may have active bleeding, which is be too risky. So if the patient is actively bleeding, we'll have to disturb the policy. You'll have to give him less anticoagulation. If the patient has had heparin-induced thrombocytopenia, again, you cannot give him heparin. If the patient platelet count is less than 100,000, again, it's dangerous to give him anticoagulation. If the patient is already receiving drugs which disturb his platelet function and the platelet inhibitors, it has to be stopped 2 weeks or at least 1 week prior to surgery. And if the patient has a disturbed kidney function, again, this will alter the dose of the anticoagulation. Use of the intermittent compression. The intermittent pneumatic compression is also not universal. You cannot use it in a patient with a peripheral arterial disease with compromised limb circulation. You cannot squeeze his limb and induce thrombosis of his arteries and acute ischemia of his leg. A patient with congestive heart failure, if you push too much of this fluid to the heart, his limited limbs with the compression, you can induce immediate severe heart failure from that. So these patients with, again, patient with superficial or deep venous thrombosis, is contraindicated to use the pneumatic compression for this group of patients. So I'm not going to say that we managed to achieve the guidelines of this practice all over the board, across the board for all our units, but it's our aim in our unit to do that, and the aim of our society, the Egyptian Society of Bariatric and Metabolic Surgery, to try to standardize the practice, because it's a problem of VTE. It does not only involve the deep venous thrombosis and pulmonary embolism, but more seriously now with the sleeve procedure, we are facing porto-mesenteric venous occlusion, which for the record, over the last 2 years, we had 5 cases referred to our tertiary research center from other areas who has been suffering from this problem after sleeve operation, not the bypass. For some reason, the sleeve seems to be more prone to this complication. At the same time, during these 2 years, we had no cases of DVT or pulmonary embolism in our tertiary heavy load place. So all these are important points to be discussed, to be studied, and we are really fortunate today to have our next speaker who is going to present to us live from Baltimore, from Johns Hopkins, the renowned hospital in the USA and university, Dr. Kimberly Steele, a professor, associate professor of surgery, bariatric surgery in Johns Hopkins, who's responsible as a director of the adolescent bariatric surgery unit there, and also the director of the bariatric research. She's going to present her take or their experience of the thromboembolic prophylaxis in bariatric surgery. Yes, we can see Dr. Kimberly. Hello, Dr. Kimberly. We can see you on our monitor. It's our honor and pleasure to have you with us, and thank you for giving us your time. We have an audience of different levels of surgeons, many of our younger colleagues, as well as experienced bariatric surgeons from the region, not just from Egypt. We have people, surgeons flown from UAE to attend the meeting, and they are all waiting to hear your lecture about your experience. And are we doing enough for our patients with the VTE prophylaxis? I think that was the title of your talk. So please, if you can start.
Sure, I'm happy to. I don't have my PowerPoint up yet. It disappeared. Shall I just go in and put it on the screen?
That's
I have my
that's
phone
normal
up.
everywhere. Don't worry. Take your time.
Shall I go ahead, or am I letting you guys do it?
We'll try to sort it out together. Whoever can put it up first will start.
So I can share with you that I have my phone up, and so I can see the audio on my phone. If you want me on my computer to put my presentation up, that's fine, and I'll just go from there so you can. Shall I do that?
We can see you clearly and can hear you clearly. So if you can put your presentation, we can see your PowerPoint even through your computer. It will be okay.
Okay.
Yes. Are we doing enough? Yes, we are waiting for you.
Okay. So I have to share with you that the room on my phone there where you are is very, very small, so I can't see anyone very well, but hello to everyone. This is exciting for me to share my experience with you. Just to give you a little background about me, I am a bariatric and MIS surgeon who has practiced for 14 years, and I started at Johns Hopkins as a fellow and have been there ever since. And I was asked to present this presentation, Venous Thromboembolism Prevention in the Bariatric Surgical Patient. Are we doing enough? So I'm going to start with a reality check and this quote from a pediatrician, and that's, today's kids may become the first generation in the history of man to have a life expectancy projected to be less than that of their parents. I start this for all of the presentations I do for a variety of reasons. One, I am the adolescent director, and so I work with young children who are struggling with obesity. And two, I'm a mom of two boys who are actually here with me today. We are visiting actually at the UNC Chapel Hill Department of Surgery, and so I'm presenting from North Carolina, not Baltimore today. But we have a serious problem with obesity, and as such, we have to find ways first to prevent it. And right now, the optimal treatment, as we know, is bariatric surgery. So the current solution we have is bariatric surgery. And there are various procedures that we do. Here in Baltimore, I will share with you that most of the procedures we are doing now are the vertical sleeve gastrectomy, about 70%, and the room-wide gastric bypass, about 30%. We rarely do bands anymore. And in my adolescent population, we're doing a lot of vertical sleeves. Why do we do the bariatric surgery? Well, we do know that it's safe and durable as a method of weight loss compared to traditional methods. And the nice thing about bariatric surgery is that we're really able to reduce or even get rid of the medical comorbidities, which is so lovely. But here's the problem, and why you've asked me to speak. Despite the success of bariatric surgery, venous thromboembolism is one of our two top leading causes of morbidity and mortality in our bariatric surgical population. And despite our interventions, the incidence of VTE, DVT, and PE in the perioperative period ranges anywhere in our literature of 0.3% to all the way to 3.8%. And before I go on to what causes a VTE, I will tell you that the objective of my presentation today is to share with you my findings from my PhD doctoral thesis. And as a clinician, I am really lucky to have my patients as the motivators for doing my research. And my PhD stems from being in the trenches with my patients, seeing these DVTs, and asking, are we doing enough? And there really are no standards of care. which led me to my PhD and questions about the type of anticoagulation that we use. In Baltimore, my colleagues and I were using Lovenox or enoxaparin, and we had one other surgeon who used heparin. I also sat on a committee for VTE prevention, and there was question about using other drugs, such as apixaban, such as Arixtra, and or fondaparinux. And I wanted to try it, but we had to do a study first, and that was our randomized controlled trial, which I'm going to share with you, and that's coming up. But before that, let's go to what causes a VTE. Well, we know that there's a fine balance between clotting and fibrinolysis, and there's numerous factors that affect the balance, and that's Virchow's triad: the blood, the vein, and flow. In obesity especially, and in any type of surgery, when a patient is put to sleep with the anesthetic, we induce stasis, we induce hypercoagulability, and there can be vessel wall injury, especially in a patient with obesity. What are the intraoperative factors contributing to thrombosis? Anytime that we operate, well, there's Virchow's triad. There's our reverse Trendelenburg. So when we do bariatric surgery, our patients are placed in steep reverse Trendelenburg, where all of the blood is pooling in their legs. There's our pneumoperitoneum, and the pneumoperitoneum causes intra-abdominal pressure, which then decreases the blood flow. And then there's our long OR time. So I saw in the presentation before that patients receive 5 points if the OR time is over 3 hours. Well, a gastric bypass is usually about 2 to 3 hours. And then there's inflammatory mediators, and those are much higher when we induce any trauma, like surgery. But in our obese patient, there are even higher inflammatory markers circulating because of the inflammation just from obesity itself. And so altogether, whether we're doing surgery or operating on bariatric patients, this is a huge public health relevance here. And this is where my slide gets stuck. If someone there could help me. There we go. So in the United States, what is the annual incidence of VTE? Well, we know that just blood clots alone, there's over 350,000. And those blood clots lead to long-term complications such as pain, swelling, discoloration, skin changes. And we also know that 50% of patients who have a DVT will suffer another DVT or sequelae from that, like a PE. The PE number is over 277,000. And those PEs can be significant, especially in our bariatric population, and can cause things such as sudden death. It also can lead to pulmonary hypertension in our patients, who sometimes even, we know that our obese population has hypertension, pulmonary hypertension to start with. And then VTE does lead to a significant amount of death in the US, where we see the estimated number of Americans suffering from DVT or VTE, PE, to be about 60 to 100,000. So what about the burden of VTE in the bariatric surgical patient? Well, we know it can be deadly and that it causes long-term complications. So in our patients with obesity, their risk is about 30% higher than average normal weight patient. And recurrent VTE is about 40%, and post-thrombotic syndrome about 30%. It causes an increased length of stay, and that increases cost. So in America, that ranges anywhere from $7,500 to $16,600 per patient, or $2 to $10 billion annually for our healthcare system. So what is so odd about all of this is that despite the impressive figures, despite the public health relevance, today we really do not still have standard of cares in practice of bariatric surgeons. And I heard that with the prior doctor, that we try to standardize it, but right now, what led me to all of my research is there is no really significant FDA or American protocols that are approved regarding pharmacological prophylaxis for VTE in our patient population for bariatrics. And these are just examples of what happens when we have significant VTE. Just to show you, in the American College of Chest Physicians and also the thromboembolic risk factor consensus group, there is consensus about the risks. There's age, there's immobility, there's cancer risk, major surgery, traumas. But what is significant in all of this is obesity. And that is concurrent with everyone, that obesity does raise the risk of VTE. What are the abnormalities in obesity then? So what is causing patients to have higher risk? Well, we know for a fact that patients with obesity do have elevated prothrombotic factors like fibrinogen, von Willebrand's factor, and factor 7. There's also elevated plasma concentrations of plasminogen activator inhibitor, PA1, and elevated concentrations of antithrombotic factors such as tissue-type plasminogen activator, TPA, and protein C. We know that in patients with obesity, there's enhanced platelet aggregation, probably from inflammation and vessel damage. And there is also shown fact that there's deficiency in antithrombin 3, which is part of our cascade, and in which antithrombin 3, these anticoagulation medications work on. And then hormonal balances. It is known that patients with obesity have much higher levels of androgens and catecholamines in their system. One thing to mention in our practice, women are asked to stop any type of birth control pills or any type of estrogen. So birth control pills that contain estrogen or any estrogen medications at least 1 month prior to surgery and 1 month after surgery because of the increased risk. And I will tell you, I've had young kids, young girls, come to surgery and forget to take their, forget to stop their birth control. And I have elected to not do the surgery and wait until they have waited a month to be off of these medications because the risk is too high and these surgeries are elective. So it is better to be safe. What are the general approaches that we use in our practice here for VTE prophylaxis in our patients? Well, again, just to remember, because I think it's such a big point, there is no consensus to date for the most optimal care and prophylaxis for our patients. If you poll bariatric surgeons here in the US, surgeons do various different methods to prophylact their patients. Most surgeons, though, however, I will agree, do a combination of techniques. The most important is ambulation. Our patients, my patients, I educate them before surgery, and they know no matter what, 4 hours after surgery, we are up and walking. And the more they walk, the better they do both with their lungs and with decreasing the risk of DVT. Mechanical, we do use sequential compression devices and compression stockings. Those compression stockings and sequential compression devices are placed and started prior to induction of the anesthetic. Why? Because we do know that the highest risk of forming a blood clot during surgery is on induction of the anesthetic. IVC filters, I heard mention about those, and I will say that we did use these quite a bit many years ago. and then pharmacologic. And most surgeons do use some form of pharmacologic medication. Going back to the IVC filters, I will say that we are not using them anymore here in our practice because we did find that they were actually causing more harm than good. After placing these, we did see an increased risk of bleeding and more blood clots. And I will show you in my research what we did find that's coming up. Ambulation is so important, and just to put out there that the American Chest Physicians VTE guidelines for all non-orthopedic surgical patients and is to walk, early and frequent ambulation and mobilization. Again, most people and most studies say that mechanical prophylaxis is important. And that is in combination with chemoprophylaxis. This is just for a break for all of you, for a smile. Look, a letter from my doctor. I have to wear those tights to prevent DVT when flying at 30,000 feet. So what's your excuse? And I put this in because my boys love the superheroes. Pharmacologic prophylaxis. Again, there is no class 1 evidence to guide our specific recommendations for use of anticoagulation medications in our surgical patients with obesity. The American Metabolic and Bariatric Society has come out with a statement for guidelines, but again, no standard protocol across the US. The American College of Chest Physicians recognizes heparin, low molecular weight heparin, such as enoxaparin, and fondaparinux, a factor Xa inhibitor, as well as aspirin as anticoagulants. Now, the fact that they do recommend all of the things, again, I will tell you that we use heparin and enoxaparin. And the question arose, why are we not using fondaparinux? Because it's once a day versus twice a day, and that would be nicer for our patients. And that led me to my research. Just some pictures of the different types of medications that we use. Also share with you, I just recently had foot surgery and my doctor for no reason put me on aspirin. Maybe it's because I'm old now. This is a very busy slide, but basically it is comparing the different types of medications, unfractionated heparin, low molecular weight heparin, and fondaparinux and aspirin. Well, it is busy. Just to go over, heparin is a porcine. Low molecular weight heparin is porcine. Fondaparinux is synthetic, and aspirin is from willow bark. The unfractionated heparin and low molecular weight heparin both work by binding to antithrombin, and that accelerates the effect of factor Xa and thrombin to create anticoagulation. Fondaparinux works by increasing anti-10A activity on antithrombin. It binds with antithrombin and attracts the factor 10A, which then causes the anticoagulation effects. Now, what I thought was important to show you is the dosage. So down here, heparin, we use in our patients 5,000 international units 3 times a day. The low molecular weight heparin, enoxaparin, we use 40 milligrams twice daily, sub-Q. And that is in our patients up until a weight-based. Over 400 pounds, we will go up on the dose of enoxaparin. And then fondaparinux, which again led to my research and wanting to do a clinical trial, was at the time when I did this study, there were no studies that had or shown optimal dosing in our bariatric patients. And that's what motivated me for the research. Just to go to the IVC filter, the first filters were permanent, and that was the Greenfield filter and the Mobin Uden filter. but there were problems with keeping them in. And so we went and had retrievable filters. And for many years, even in my practice, the hematologist did recommend for patients who had the inability to use anticoagulations for whatever reason, bleeding, or were high risk, we put the filters in. And in fact, the American Chest Academy physicians do recommend filters for those patients where anticoagulation is contraindicated. However, there really is a lot of controversy because now studies are showing and providing evidence that these filters, again, may be causing more harm than good. And so this is where it led to all of my work. What I wanted to do was figure out the effectiveness of current and future practices for VTE prophylaxis in the bariatric population in my patients. And so I was able to do 4 publishable units in 3 years with my 2 boys who were at the time 1 and 2 years old. The first one was looking at the long-term risk. I felt like we needed to know more about what was the long-term risk in our bariatric surgical patients to better understand whether we were doing the right thing. And I also wanted to question whether use of IVC filters were the right thing. So that was the first study. The second study led me, when I did this retrospective review, I found question about these filters. And so the next study that I was motivated by was this prophylactic IVC filters. Is that the right thing? Does the benefit outweigh the risk? And what we found was that the body habitus really presented a technical challenge in placement of these IVC filters, and further, the detection of asymptomatic DVTs. Were we missing the asymptomatic DVTs that could be deadly? So then we tried to think, well, what are the best ways to detect VTEs in our patients? And that led to doing a systematic review and meta-analysis on the accuracy of using MRV. Could that be a method that would be better than a CT angiography, which is the gold standard, or duplex ultrasound? And then finally from there, my big work, and what took a long time to accomplish, was my randomized controlled trial, where we took 2 different forms of anticoagulation, enoxaparin, which we were using, and fondaparinux, which seemed to be a better option because it was once daily dosing, and studying the incidence of asymptomatic DVT. Not symptomatic, though we did also look for those, but we wanted to see whether we were missing DVT in our patients. So in my first publishable unit, the specific aims were the duration of risk. We wanted to see how much of a risk late VTE was. And that is defined as greater than 30 days, mostly because the evidence reported in the literature is short-term evidence on post-op DVT. And then 2, we wanted to identify specific characteristics that may predict an increased risk of VTE in our bariatric surgical patients. Our hypothesis was that the risk of VTE is elevated beyond 30 days, that we are actually missing more DVT further on. So in other words, are we doing enough by just doing perioperative VTE prophylaxis? Should there be extended prophylaxis? And I heard from the last speaker that when the patient has severe or elevated risk, that they do 2 weeks of extended prophylaxis. In our practice, we're a little more conservative, and we actually do 30 days of extended prophylaxis, as long as the patients are compliant with all of those needles. So we wanted to look further beyond that 30 days and detect certain demographic characteristics and pre-existing medical conditions, the comorbidities that will help us predict what increases VTE risk in the bariatric patient. The methodology that we used was a retrospective analysis based on a very large administrative database. This was an insurance database from Blue Cross Blue Shield. and that helped us to determine long-term risk. And these are our results. And what we found, if you look here, is that over a year's time, there was cumulative increased risk. So the incidence, the cumulative incidence of VTE and PE accumulated over time. So we are missing some VTE reported events. And so again, that questions, are we doing enough in our prophylaxis of the bariatric patient? Our conclusions from that study was that the period of increased risk for VTE following bariatric surgery extended well beyond the index hospital discharge and 30 days postoperatively. And that raised the questions that maybe surgeons do need to consider more aggressive extended prophylaxis in our patients. So in the evidence, we know that males have a higher risk, age greater than 55 has a greater risk, and previous history of any type of VTE episode increases the risk. And then the length of the hospital stay, which indicates the illness of the patient, the sicker that patient is. As well, smokers have a higher risk, and we also do know that higher BMI. Now, I have a question mark there of greater than 50, and that's because, again, there's not evidence in the literature, there hasn't been good studies to suggest what the cutoff is for that BMI. In our practice, our cutoff is greater than 50, and we will extend the prophylaxis. So if a patient comes in and they are over the age of 55, so 60-year-old patient, they have a BMI over 50, they will be sent home with 30 days of postoperative prophylactic medication. The next publishable unit from there led to complications from IVC filters. What are the complications? And so the aim was to determine the incidence of post-op complications reduced to the use of IVC filter in our bariatric patients. We believe that patients who did undergo IVC filter placement prior to surgery did have an increased risk, and that was from, again, our clinical practice and what we had seen clinically. And those include postoperative bleeding, complications, and extended length of stay. What was the methodology? Again, we performed a retrospective analysis. We looked at a large administrative database. This was, again, Blue Cross Blue Shield data from over 20,000 patients to determine the incidence of postoperative complications. We searched for patients that had IVC filters placed before surgery and then followed them to look for complications. And these were our findings, which were revealing. We did see that patients who had a filter placed before bariatric surgery had higher incidence, so their odds ratio, a 2 times higher risk of DVT, and they had a 3 times higher risk of bleeding. So what do we conclude from this retrospective study, which made us question? IVC filter placement in our bariatric surgical patients does not reduce the risk of PE in our high-risk bariatric surgical patients. And in fact, most of the time we will use pharmacological intervention rather than IVC filter. And the use of these IVC filter placement in our high-risk bariatric surgical patients may actually cause more complications postoperatively. So then the question is, are we doing the right thing by operating on these very, very high-risk patients that may have such bad comorbidities and postoperative complications that their surgery is not even going to benefit them because they're suffering from these terrible complications? And so that leaves us as researchers to find better methods for both treatment of obesity, and if we're going to operate on them, then we need to find better methods to protect them. Then my next publishable unit was looking at MRV. I was interested in the fact that we right now use duplex ultrasound to detect DVT in our patients, yet there's such evidence that duplex ultrasound may not even work in our patients who are morbidly obese because it's technically difficult. And so we don't like to use CT angiography because it is so invasive. And the question arose, well, from my radiology colleagues, should we be using MRV? And so we did a systematic review and meta-analysis. And we wanted to look to see whether MRV is an effective diagnostic tool in the detection of suspected symptomatic or asymptomatic lower limb and pelvic DVT. And our hypothesis was that MRV is an underutilized, non-invasive diagnostic tool, and that we should possibly consider it for use in special populations when the patient, such as an obese patient, has high risk and we need to treat them. In most cases, in our practice, because MRV is expensive, I will tell you that we treat the patients if we suspect it and don't even wait for the diagnosis, unless, of course, we're very worried about bleeding. Our methodology, we did do a systematic review and meta-analysis of all of the previously published observational studies that we could find that compared MRV to other modalities such as duplex ultrasound and CT angiography. So I'd like to talk a little bit about the background here before I give you the results. The current standard is DVT detection through invasive contrast venography. Other modalities have not been shown to be comparable. And so though we use duplex ultrasound all the time, it truly is limited by poor anatomical windows in our bariatric surgical patients. So the value of it is questioned. In fact, many of the patients, we miss asymptomatic DVTs. CT venography is much better, but it is a high risk, and there is ionizing radiation, plus contrast material allergic reactions. MRV seems to be a better way to analyze the anatomy, especially in the obese patient. And this is just an example of trying to get to a patient's lower extremities and pelvis when they have an overlying pannus. It's difficult when we're doing duplex ultrasound. And that's pretty impressive, right? So what do we do? Well, we did this systematic meta-analysis and review, and we found that MRV should be considered for the detection of DVT. Now, will insurance pay for it? No. But we did see that we were able to detect asymptomatic DVT in these reviews and meta-analysis. To date, duplex ultrasound is the general modality of choice for the detection of VTE, and the use of MRV is still not routinely used because of expense. And there's just some pictures of MRV and duplex ultrasound. So in conclusion, we did really see a significant sensitivity and specificity for MRV comparable to contrast venography, and that it is underutilized. But right now, we really do need to do further research to, I think, point out the utilization, how well we can use this for our patients. And then finally, the big study that I would like to present is my last publishable unit, and that was what we called the EFFORT trial. It was coined enoxaparin versus fondaparinux for thromboprophylaxis in a bariatric surgical patient. It was a randomized double-blinded pilot trial. My aim was to compare the effectiveness and safety of enoxaparin versus fondaparinux in the prevention of perioperative VTE in the bariatric surgical patient. Why? Because we were using enoxaparin twice a day, 40 milligrams twice a day, and we had this option to possibly use fondaparinux, which was once a day. And then our next aim was to conduct this pilot study using MRV to estimate the incidence of asymptomatic DVT. So from this meta-analysis we did, it was intriguing. The MRV seemed to suggest that we were missing asymptomatic DVTs. And so I thought it would be really neat to tack that onto this study to see whether we were missing asymptomatic DVTs in our population. Our hypothesis was that once daily dosing of fondaparinux will be as effective and safe as twice daily Lovenox, and that the incidence of asymptomatic DVT, especially when it's in the pelvis where it's hard to detect with duplex ultrasound, will be higher than previously suggested or recorded in other studies. Our methods. We used 40 milligrams of subcutaneous enoxaparin twice a day, and we compared that to 5 milligrams of subcutaneous fondaparinux once daily in our bariatric surgical population, initially on hospitalization in the perioperative period. This was randomized and it was double-blinded. 2 weeks following surgery, we then had the patients undergo MRV to detect the presence of asymptomatic DVT. Prophylaxis for VT is routinely performed for all patients undergoing bariatric surgery. And again, to reiterate, there is real disagreement with the optimal dosing and duration of anticoagulation therapy. And there's little data regarding the incidence of asymptomatic DVT. So from July 2010 to 2013, I recruited 198 consecutive bariatric surgical patients from our center. So they were all operated on by the same surgeons. And these patients were randomized in a double-blinded fashion to either receiving enoxaparin 40 milligrams twice daily or fondaparinux 5 milligrams once daily in the perioperative period. Just to give you more information about that, the patients who were in the enoxaparin group received 40 milligrams of enoxaparin on call to the operating room, whereas the group that was randomized to fondaparinux had a placebo on call to the operating room. 6 hours after surgery, the patients in the fondaparinux group received the 5 milligrams of once daily fondaparinux. Why did we choose fondaparinux 5 milligrams? Well, there was recent literature at that time for me to say that 2.5 milligrams in the obese population was not sufficient. It was it did not meet the therapeutic levels. And so we chose a higher dose. And in fact, I had to ask the FDA for an IND to use the 5 milligrams. 2 weeks following the surgery, we then had the patients return to clinic to undergo an MRV, and we wanted to look for the presence of asymptomatic DVT. Now, of course, we also did very thorough history and physicals and made sure that there were no presence and recorded any history of symptomatic DVT or PE as well. Again, our primary outcome was the effect of the pre-op enoxaparin versus the post-op fondaparinux prophylaxis on anti-factor Xa concentrations in our patients that underwent bariatric surgery. The levels were drawn 3 hours after receiving the drug on post-op day number 1, and the cutoffs you'll see here we used were 0.2 international units per mil for a Lovenox or enoxaparin, and greater than or equal to 0.39 milligrams per liter for fondaparinux. Our secondary outcomes were asymptomatic DVT, positive MRI that we did at 2 weeks following surgery, or symptomatic DVT. And then our safety outcomes, we looked for perioperative bleeding and perioperative complications, as well as death. This is a little difficult to see, but I hope that you can see the structure. Our enrollment, we had 320 bariatric surgical patients that were screened. Of those, 103 were not eligible because of our inclusion-exclusion criteria, which include previous VTE. 19 patients just did not want to participate, and then we had 198 that were randomized. 100 of those patients were randomized to fondaparinux and 98 to enoxaparin. We analyzed those that would tolerate the MRV because some had some anxiety and did not want to go into the MRV. We were able to convince 94 in the fondaparinux group to do MRV and 83 in the enoxaparin group. And our final results on MRV, we had 2 asymptomatic DVTs in both groups. What were our baseline characteristics? Well, our patients looked very homogeneous with regards to gender, age, race, weight, height, and comorbidities. So both groups, whether they were randomized to enoxaparin or fondaparinux, looked very similar. 83% or almost 84% were female. The mean age of our patients were 41.1 and our pre-op BMI 45.4. 75 underwent the laparoscopic vertical sleeve gastrectomy, or 38%, and 123, 62% underwent the lap gastric bypass. And I will point out that now in today's universe of surgery, this kind of has flipped. We are doing more sleeve than bypass. And the mean OR time for the sleeve was 156 minutes and the gastric bypass 202 minutes, just so that you understand how long the patients were on the operating room table with increased risk for VTE. The average length of stay was 2.4 days. And this just gives you a table showing our demographics that looked very, very similar with respect to age, race, sex, hospitalization, and demographics, the comorbidities, smoking status, and birth control use. Our outcomes, well, of the 198 patients in the study, 137 had valid anti-factor 10A data. And of those 137, what is most interesting was that almost half, 47.4%, were found to have inadequate anti-factor 10A levels. So in both groups, we were not prophylacting the patients to a dose that we would say is adequate. And very important was that more patients reached target prophylactic anti-factor 10A levels on the fondaparinux than in the enoxaparin group. In the fondaparinux group, 74.2% did reach the prophylactic anti-factor 10A levels, whereas in the enoxaparin group, only 32.4% did. So this was significant. And here's a nice view of it in graphic form. You'll see on post-op day number 1, the fondaparinux is in the blue, the enoxaparin's in kind of this reddy, rusty color. I didn't choose the colors, I apologize, but you'll see that the fondaparinux did reach therapeutic levels much better than the enoxaparin did. And then our secondary outcomes were also important. Of the 175 patients evaluated for asymptomatic DVT by the MRV, there were 4 positive DVTs, or 2.3%, in the range that is quoted in the literature. What was important was these were asymptomatic, and there were 2 in both groups. So we treated those patients. The question is whether those asymptomatic DVTs would have been anything should we not have treated them or found them. Are there more patients with asymptomatic DVT that we don't even know about? And all 4 DVTs were large, very large, and located in the left common iliac vein. And here's just a sample of one of our patients on MRV, a beautiful picture on MRV with this very large left iliac DVT. Then as far as our primary, secondary, and safety outcomes, just to show you. The primary outcome again, fondaparinux reached therapeutic levels in 74.2% of our patients versus enoxaparin in only 32.4%. And then as far as the development of DVT, what were the things that would indicate to us that patients were at higher risk? We believe that our groups were too small to show the significance, but there were trends. For example, pre-op BMI. So again, a higher BMI increased the risk of developing a DVT. The age, patients over 50 had almost a significant increased risk. And then what trended but was not reaching significance was hypertension, so a preoperative history of hypertension, a preoperative history of type 2 diabetes. Then what about our adverse events? What did we see in these groups? Well, importantly, we did see 8 patients had minimal bleeding. In the Lovenox group, we had intraoperative bleeding. Oops, sorry, that one. We had intraoperative bleeding in 4 of the enoxaparin patients and 2 in fondaparinux. We did see 1 rectus sheath hematoma in one of my patients post-op, having been randomized to fondaparinux. And then we had 1 patient in the enoxaparin group with bright red blood per rectum. We did see 3 total patients with rapid AFib post-op, but note that these patients did have intermittent AFib pre-op, and most likely this was a significance of the surgery itself. 1 patient did have an elevated creatinine and fondaparinux, remembering that it is cleared through the renal system, and 1 patient did develop thrombocytopenia. I'm sorry, I have a cold. What were the limitations of our study? Well, we treated all cases as incident cases, but we did not obtain ultrasound or MRV imaging preoperatively, and so we can't exclude that clots may have been there before surgery, again, as asymptomatic clots. And then we did have a small study sample size. You know, one of the problems in surgery that we face and are challenged with is we rarely do multi-center trials with big numbers, and really that's what we need to be doing to get our answers. However, we can see some trends, and there was significance in the therapeutic levels. What were the strengths of this study? Well, it was double-blinded, it was randomized, and we used a novel means of detecting asymptomatic DVT. There was nice homogeneity, so both treatment arms were very similar, and I will say here in the States, I'm not sure what your population is like there, but here in the States, we have a very large female population, which this was mostly of. The mean age is around 45. In this study, it was 41. And the mean BMI is around 45, which is what this study did have. So we do say that this population that we studied was fairly representative of what we see in our academic bariatric surgical centers in the U.S. What can we conclude from all of this? Well, it is, or was, the first reported double-blinded RCT comparing 2 different blood thinners for the prevention of VTE in bariatric surgery. It was the first study to have the Paranux. All of the DVTs that were reported in this study were asymptomatic, and there were no difference in the rate of DVTs seen between enoxaparin and fondaparinux in both arms. So what this really does say is that once daily fondaparinux dosing was much more likely to produce target antifactor 10A levels than the twice daily enoxaparin. In our practice, we do use validated scales like the Caprini to evaluate our patients, and we use the EMR ways to absolutely target our patients so that we are doing as best standard of care as we can, but we still need to do better. And that comes from better research studies. And just to talk about one other possibility that we may be using one day in our patients, I also know that some of my colleagues are using these already, are the new oral anticoagulants, or NOACs. Now, these are on the market. They're being used for other types of prophylaxis in AFib and medical diseases. I'm not aware that they're being used very much in the prophylaxis in surgery. The question is, could we use them one day? Again, I was motivated. One of my colleagues used this medication in one of his bariatric patients, and I said to him, you know, that the findings might not keep the patient off of that medication. And so now we are doing a randomized, a clinical trial looking at these new oral anticoagulants, so that one day maybe we could be using these rather than having to use injectables, which are not fun for the patient. And so these orals, as Fondaparinux does, working on factor 10A, apixaban, and I can never say it, rivaroxaban, or rivaroxaban, and dabigatran are some of the new oral anticoagulants that we have not used in our bariatric patients, but do consider. And that leads me to the current trial that I am working on. It's called the APB study, and we are looking at the apixaban pharmacokinetics. We're almost done. It's taken about 3 years, but we hopefully will have the analysis out soon to determine what dose we need to use in patients with a BMI over 35. And that will be coming out. We also looked at the difference in the absorption in the sleeve and the gastric bypass patients. So we ran patients. So stay tuned. That's really what I have to share with you. My personal acknowledgement to now. Thank you so much for your time. It's laggy. It's laggy, so I'm.
Thank you very much, Dr. Kimberly. If you may have some of your time to just have some quick questions, I'll start off with.
Absolutely.
If you can hear us.
Yes, it's just laggy. So I'm watching you on my phone. I don't see you on my screen, and you're about 10 seconds behind me and what I'm saying.
Okay. I just wanted to ask you, I'm Professor Ala Abbas, I'm head of Bariatric Surgery Unit at Ain Shams University in Cairo and the president of the Egyptian Society of Bariatric Surgery. I've been practicing bariatric surgery for 24 years now. You didn't mention if you have any specific plan for your prophylaxis in the adolescent group. Your studies were all at the age of around 41, and I understand you are interested in doing the adolescent surgery. So are there any difference in giving the prophylaxis to this younger age group?
Can you hear me?
Yes. Yes.
Hello?
Yes, we can hear you.
Okay, good. And everything, I see you asking the question, and then I'm seeing me do weird things with my hands and that. It's very laggy, so I apologize. I think I heard the question was, do I do different prophylaxis in the adolescent bariatric patient?
Yes, that's the question. Yes, please.
Is that correct? Should I maybe turn my phone off? The computer doesn't seem to be working.
Yes, we have an advice here from the technical gentleman saying that if you stop sharing your photo, maybe the screen, stop sharing the screen, maybe the voice will be heard easier.
stop sharing the screen. Oh, so can you hear me now?
Yes, we can hear you better.
Okay, good. Yes, now I see you and I see the room, which is much nicer, so I can see people. The question was the adolescent group,
Yes.
right? And the anticoagulation in the adolescent group.
Yes.
If I do the same thing, I absolutely do the same thing. The kids, I mean, I think, again, more research needs to be done, and it would be very interesting to see whether the inflammatory markers in the kids and adolescents is any different than in the adults. Suggest, and what we've seen is that by intervening sooner, we decrease the end organ damage, and that occurs because of the inflammation and obesity. So maybe our adolescents actually have less inflammatory markers, or the contrary would be that because there are systems that maybe their inflammation is more. So in that regard, my practice is to follow the same routine with DVT prophylaxis. And in fact, in that age group, we have to be very careful about birth control. One, teach and recommend that these kids are off of the estrogens, any type of estrogen, a month before and a month after surgery. At the same time, we have to educate them that it's really important that they engage in safe sex so that they don't become pregnant during this time. We've had a couple of patients show up and the urine test is positive. So important in the age group. It's really important. So these kids, educate them about that with weight loss, there will go up. Now I can't hear you again. I lost them.
We can hear you, but we lost your picture also. If you hear me, I would like to just add another question. What age range you consider starting your surgery in the adolescents? How young? And do you calculate their weight with the BMI or is the percentile in the adolescent group?
There. Can you repeat the question? I'm sorry, I lost you.
Yes. I'm asking about the age of the adolescents, what is the age you start with, and do you calculate their weight with the normal BMI or with the percentile?
It's an excellent question. So in our practice right now, we have been limiting and not going any lower than 17. Now, I will tell you that many of my colleagues are going lower. I just came back from Stanford where one of my colleagues convinced me that 16 really is the best age for these kids. And that's because, and actually I had parents convince me of that, because they're still at home before they go off to college. And so they have the support from family. And I think that's reasonable. I have another colleague down at DC Children's who starts very early, and Dr. Nadler, who will operate on kids as young as 10 years old. I'm not ready for that yet, unless someone convinces me that that's the safe thing to do. And again, I think that's where research and evidence is needed. The ASMBS and the American Pediatric Society just came out with very nice guidelines about bariatric surgery. I think that you can search it, or I can share that article with you. It's a lovely synopsis, and it gives guidelines for bariatric surgery and is recommending to pediatricians in the U.S. that we consider bariatric surgery earlier as an intervention for kids. However, there is always a but, and the but is that this is done in a center where we take it extremely seriously and provide the resources for the family and the children, and that there is extensive workup, both physically, so clinically, but also psychologically for these kids, and that we just don't dive into it. In other words, that we do our best to provide traditional methods, work with the family and kids, and should all else fail, that bariatric surgery should be considered. And saying that's what I. So again, the guidelines now do not look at percentiles. We do look at weight and BMI, and that's what the ASM is going with right now. So a BMI greater than 35, but with medical comorbidities, and a BMI greater than 40, and the child does not need to have medical comorbidities.
Excellent, thank you. I would like just to ask some of the colleagues here in the floor if they have any question to Dr. Kimberly. Anyone who wants to ask a question, just raise his hand. We'll send him a mic. Yes, we have a consultant surgeon from UAE. He'll present himself and give you a question. Dr. Kimberly, please.
Yeah, I am Dr. Ibrahim Nagoumi. I am from Dubai, head of surgical department. My question to you, if you have kids of 14 or adolescent, as Dr. Ala said, and you choose bariatric surgery, because I found some controversy between leaders of the world about this. Do you choose a sleeve gastrectomy or bypass surgery?
I'm sorry, I couldn't hear. It went in and out. Could that question be repeated?
If you choose bariatric surgery for adolescent, like 14 or 16 years old, which operation you choose? You choose LSG or gastric bypass?
Right now, I will say that the majority of my colleagues and myself will lean towards the vertical sleeve gastrectomy, especially in the younger kids where we are concerned about calcium absorption and bone growth. So again, my belief is we should make sure that both is tend to work or use the vertical sleeve gastrectomy. However, and this is a big however, if the child has severe reflux that is diagnosed or has a large hiatal hernia, you then really have to question whether, and I'm sorry of my voice, you have to question whether the sleeve is the right procedure and whether if the sleeve, if the reflux is so bad, then gastric bypass to be considered. And this is the bypass might be some type of bowel or previous surgeries, it has to be very individualized. A lot of work in the research area is trying to figure out what those predictors are, what we can look for to help us better determine what's the right procedure for our patients. The nice thing about the sleeve in an adolescent is that it carries them through during their young ages, and should they need further surgery, you can convert a sleeve to a gastric bypass when they're older. So that it is an option as well. But I do think each need individualized. And before we jump to making decisions, we have to weigh the options and the patient's individual comorbidities for what procedure is the right procedure. I hope that was helpful.
Thank you. Maybe one last question before your voice goes away completely. I would like to have your input about the portomesenteric thrombosis following the sleeve. Do you have any experience or comment about this? Because we have seen a few last 2 years.
You mean seeing blood clots in the portal system?
Yes, we have at least 5 cases in our country over the last 2 years. We presented with actual venous thrombotic problem, with some of them had to go for small bowel resection and exteriorization, and some went well with only high dose of anticoagulation. And we have never seen this following the bypass procedure, and always almost after the sleeve when it does happen.
I think
input about this.
I will tell you, I've had several of my colleagues contact me in absolute disbelief and scared because they have had patients who have clotted off their portal or splenic vein, and it leads to terrible comorbidity. And you're right, it's happening in the sleeves. I don't think we know what the etiology is yet, but boy, that's a really important thing that we need to look at. If you want to get together with me to try to put these cases together, it might be something good to look at what is predicting or predictive of these blood clots. You know, I can only think that mechanically, maybe as we are stapling across, or the fact that we're taking the splenic blood supply and creating some different pathway of blood flow. But I don't know yet. And I've had, again, several colleagues call me asking, what do we do? And they want to know about these oral anticoagulants because they were hoping that we could start to use them. But we don't have the study out yet. So it's a very, very important, excellent question. I would like to ask you, of these 5 cases, did the patients have any higher risk? Did he undetected protein C or antithrombin deficiency control smoke that increased their risk at those 5 cases? Hello?
Yes, we studied these patients after the event, and they had always had all negative for protein C, protein S, and all the other parameters. But I think with your vast experience in thromboembolic research, you have to carry the torch and design a study how to work on this subject. and we will follow you.
Okay. Okay.
Thank you. Anyone else have questions?
It would be nice to actually work with you to see those 5 cases, and perhaps I should reach out to my colleagues to gather their experience with these cases, because what we maybe need to do is first look retrospectively at them and then go from there on how we do study it, because it's very scary, and we need to know what to do.
Yes, we will try to get you the details of these cases retrospectively through our partners here at Aspen in Egypt. And we will wait for your ingenious design for the study to find out how to avoid this.
Okay.
Thank you very much for your time. We enjoyed your work, your research, your passion in the subject, and we wish you all the best. Thank you for your time again.
Thank you. Thank you so much. I have to tell you how exciting it was for my boys, who are 9 and 10, to know that their mommy was talking to all of these doctors in Egypt. So thank you.
Thank you very much.
Bye, everyone.
Thank you. Thank you. We will have a coffee break for 10 to 15 minutes, and then we'll resume. Thank you.
Bye-bye.
Bye-bye.
هو الانترنت عندها، انا جربت من جوت ميتنج على الموبايل نفس التقطيع كان ب 3 جي بسبب الانترنت بتاعها.
طب احنا نطلب منها ايه علشان ده كده ما يحصلش؟
نوت شير، يعني مفيش حد من الاطفال يكون بيستخدمه.
طيب يلا بس نخلص عشان تطلع لي بس الكود لميتنج بكره.
حالا اعمل.
اوكي بليز انا بدايه Oh, really? Okay, I don't know.
ايه ده؟ اه ريكورد ايه؟ الديمكس مفهوش اي حاجة خالص. مين ايه؟ لو النبي خضتني.
We resume our scientific day today. The next presentation will be from Dr. Asri Benkritli, who's going to present
Can you show my slides?
about the French experience. The slides may be in French, but he's going to talk us through it in English, hopefully.
Sorry, some slides will be a mixture of French, English. There is no Arabic for the moment, but next slide, next presentation, I will try to have some. Just to show you the very small part of one specific information we got from one survey performed in France, to show you how the bariatric surgery interventions are growing fast in France. This is the evolution, and you see that between 2003 and 2016, the total number of interventions has dramatically increased very quickly, mainly ladies here, but the total is not far away from 60,000 interventions a year, which is a lot. You may probably know that France is the 4th country in the world in terms of number of intervention. The first is the US, the second is Canada, the third one is Brazil, and in the 4th position you have France. This is due to many things, and probably one important thing is the reimbursement by the Social Security in France, which in certain conditions with indication specified, the patients are totally reimbursed, whatever is performed in a public hospital or private hospital. So that's probably one explanation. I would like to remind you what's the French Society of Anesthesiology in 2011 guidelines indicated related to the bariatric surgery high-risk patients. It's clearly stated in these guidelines that the patients needs to have pharmacological thromboprophylaxis, of course, in addition to mechanical thromboprophylaxis tools. It stated also that low molecular weight heparins are recommended. They don't specify which drug to use, but as you see here, in those old 2011 guidelines, fondaparinux was not included in the guidelines. Those guidelines were mainly coming from the US, and it was not specified that fondaparinux was indicated. The daily dose must be increased to a maximum of 10,000 units a day. This was stated in this recommendation due to the risk increased of bleeding. And the recommendation at that time was 2 injections per day for the patients in bariatric surgery. And it's, of course, recommended in addition to use IPC for those patients. But at that time, the guideline was stating that no study has established recommendation for the initiation of prophylaxis. Should it be before intervention? Should it be after intervention? The second questions unresolved at that time, and maybe still not resolved, is what's the duration of this prophylaxis? And we will discuss during the question after that. And by analogy with digestive surgery, they recommend a minimum duration of 10 days, but you understand that it's not specifically, has not been studied in this study. That's why in 2017, well, in 2016 the study was performed and published in 17 in 37 specialized centers managing obesity patients in France. And of course, in these multidisciplinary teams, questionnaires were sent with 17 questions. Those investigations were performed by paper and by mailing and phoning. And they received a number of answers, very satisfying, of 34 on a total of 37, which corresponds to 92%. And you see here that those centers are in the different part of France. The first one of the questions, I selected some questions for you. You will not have the 17 questions. But my first question for you, asked to the French doctors, were, is there a specific protocol of anticoagulation for severe obese patients in your hospital? Who can answer yes? Raise your hands in the room. Do you have in your hospital, in your center, a specific dedicated protocol to use anticoagulations in surgery patients? One. Who has also a specific protocol in his department, in his hospital? Only one? No specific protocols. So you can use what you want, the dose you want, the duration you want. It's free. It's not standardized. Okay. This is the answer coming from the French investigators. Yes, it is in a total of 98%. Sorry. And only 2% of the centers don't have any specific protocol. Next question. Which anticoagulation are you using after bariatric surgery in your department? And I raise the question to you. Who's using enoxaparin? One center? Any other center? Who's using fondaparinux? Center here using fondaparinux? Other low molecule weight heparins? Which one, for example? Dalteparin? Any center using oral anticoagulation? Okay. So this is the answer in France. It's mainly enoxaparin, 82%. And fondaparinux is used in 9% of the total of the patients. Next question. Which posology do you use? In enoxaparin, it's mainly 4,000 units twice a day, and only 6% were using 6,000 twice a day. And of course, very few are adapting linked to the body mass index. For fondaparinux, it's easier because there is mainly one dosage used. It's 2.5 milligram. Next question. Is this dose adapted to the BMI or to the weight of the patient? Who is adapting the dose to the body mass index or to the weight of the patients? Raise your hands. Do you adapt? BMI. For the dosage, of course, for the dosage. No, not the duration. The dose you selected. Yeah.
Yes,
no,
all
for
this is
prophylaxis. We are in bariatric surgery, only for prophylaxis. Okay, so this is the answer. The majority, well, 50% of the total of the centers are not adjusting the drug to the body weight, to the body mass index or to the weight. And only 12% are adapting the dose to the total weight of the patients. And 38% are using the body mass index. Do you take into account the history of the patients who had in his past already complications, thromboembolic venous events? Do you change the dosage? Do you integrate in the selection of your drug and the duration? Is it something that you integrate in your strategy of treatment? Who say yes? Raise your hands, please. Okay. It's 44% that integrate this element in his decision and 56 who don't. Are you choosing the dose depending on the type of surgery? Sleeve or bypass has an impact or not on the dosage, yes or not? Who said yes? Nobody. It's the case in France, 82% don't adapt the dose to the type of surgery. When do you start prophylaxis? Is it before intervention? Is it the day of the intervention? Is it after the intervention? Who says before? 1, 2, 3. Who says the day of the intervention? And who says after the intervention? Okay. So let's look at the answers. 15% of the centers are doing it before. The vast majority, 61%, are doing it the day of the intervention, and 34% the day after the intervention. I don't have hide the questions, the answers. But the question was, if you start the day of the intervention, how many hours after? Is it 5 hours after? Is it 6 hours after? Is it 8 hours after? Or is it 12 and more? And the majority is doing it after 6 hours. How many injections per day? Who's using once a day injection? 1, 2, okay. And who's doing twice a day? No one. Okay. Look at the French, great difference between France and you. The majority is using 2 injections a day. Only 30% is doing 1 injection a day. What is the average duration of the anticoagulant after bariatric surgery? Who is doing 7 days? Who is doing 10 days? 2 weeks? 3 weeks, 21 days? Very few. So the majority is 2 weeks. Okay? Do you perform biological tests during your anticoagulation? Who's doing and what? No monitoring the platelet? You don't know HIT patients, you don't look for them? HIT patients? No? Okay. So in France, the platelets are monitored in 93% of the case, and it's twice a week. Twice a week. If I ask you, do you need specific guidelines for the management of obese patients, or do you think you have enough data, enough guidelines, and you know how to manage them? Is there a need? Who wants to have more guidelines, precise guidelines? Okay. So this is exactly what was answered by the French doctors. Yes, in 94%. And what kind of information they need? Which molecule? Which dosage? How many injections a day? And the duration of the treatment. And this is what the French Society of Anesthesiology issued in 2019, some guidelines where we see for the first time that the fondaparinux is mentioned and specified integrated in the strategy of treatment for those prophylaxis patients. The dosage could be twice a day, between 3,000 and 6,000 units every 12 hours. This is a suggestion, but 6,000 every 6 hours is mentioned as having a potential risk of bleeding. It's clearly indicated. And what we see for the first time is that the daily dose, one unique daily dose, increased of low molecular weight heparin, or the usage of fondaparinux is totally possible in this type of patients. And then the duration, minimal duration of thromboprophylaxis should be 10 days. And then that's because we don't have enough data. We don't have clear data indicating the optimal duration of treatment, but the minimum should be 10 days. Those are the recent guidelines issued by the French Society, and those guidelines were issued after the European ones, because the French anesthesiologists were not in agreement with the European guidelines. We were not clear. We opened different possibilities with not clear guidelines. That's why the French Society decided to issue those guidelines. Do you have any questions? I think the dinner is approaching, so you have no questions. Thank you very much.
So our final closing remarks and recommendations, I think we all benefited from our scientific meeting today, highlighting the importance of deep venous thrombosis and pulmonary embolism risk assessment and prophylactic management in bariatric patients. This is a documented international situation which we have seen from the States, from the presentation of Dr. Kimberly Steele, and the effort of Dr. Asri, showing the latest guidelines from the French Anesthesiologist Society in 2019. And I think we are going to be encouraged to add to our routine work with our patients to assess them preoperatively for the risk and to put them on a regular policy of prophylaxis that can be applied automatically by the team through the system we have agreed upon. Start with our unit, and it is a tertiary unit hospital in the biggest bariatric unit in Egypt and maybe in the region. And we will spread our practice to our colleagues through our society to hopefully a national policy for application and collect our data and present it hopefully next year in a similar meeting. And we finally thank our sponsors, our sharers in the effort to look after our patients, give them the best care, Aspen Company. Thank you.
I just wanted to add one comment. This is our first meeting dedicated to this topic, bariatric surgery in Egypt, and not only in Egypt, but in the Middle East. And this is our ambition, to have such meeting on a regular basis in the future to evaluate the practice. And we would like to, with you, in the next 6 months or 1 year, meet again and discuss how your practice has changed, has been modified with the new things, with the guidelines, with the discussion, with your own experience with new a way of managing the patients, treating the patients, following the patients. And if you agree, we will maybe meet in 1 year time. Thank you. Thank you for being here tonight.
entrance to the beginning? That's it. Perfect.
The dinner will be on the next door on the left. Follow the